Hello, my name is Charlie Till and I'm one of the education team with the Scottish Ambulance Service. We're going to run through the abdominal examination skill drill, which could also be considered the gastrointestinal skill drill assessment, given that most of what we're assessing relates to the digestive system and its related organs within the abdomen, though we do assess some other organs as part of the drill. To do this drill, we'd have first considered our preliminary examination, which you'll have seen in a previous video, where we look at the patient's hands and check their arms, their head, and their mouth and their chest for any other signs or clues. So we're going to start from the point where we're focusing in and just assessing the patient's abdomen. First of all, I need the patient to be in an appropriate position. Right now, the patient is sitting too upright at about 45 degrees. We need them to be lying flatter down in a more supine position. If there's any kind of abdominal discomfort, we don't want them lying completely flat because it will tighten the abdominal muscles. It also makes it harder for us to palpate. So we really want them sitting about 15 to 20 degrees. So I'm just going to lean you back slightly. Okay, so just let the bed go down and lean with it. There we go, is that comfortable? Mm-hmm. So the patient's still on a slight incline, meaning the abdomen's not too crushed with them sitting up, but again, it's nice and relaxed in a normal position here. I'm just going to get you to rest your hands down by your side. Fantastic. So to start with, for the abdominal examination, we're going to inspect the abdomen. We're looking for quite a few things. Any obvious masses that could be either signs of hernias or an abdominal aortic aneurysm. We're also looking for any distension, which could be a recent fluid overload causing ascites, causing a swelling of the abdomen. We're also looking for any scars or marks suggestive of previous surgery or injury, and we're inspecting to see if there's any stria, which are stretch marks, which again give us a clue of any recent, unexpected, rapid changes in weight in either direction of either gaining or losing weight. Once I've inspected the abdomen, I'm going to make sure that I get down to the patient's level and look across the abdomen as well. In a particularly slim patient, you may see the aorta pulsing naturally, and that's completely normal. But in anyone that's got a slight bit more weight, any obvious pulsing could be a sign of an aneurysm. And also, you're only going to pick up any subtle pulsing by looking across the abdomen. Before this assessment, I'm going to make sure that if the patient did need to use the washroom, they have done so, because it may be a bit uncomfortable and create some pressure across the abdomen, and it may increase their urge to need to use the toilet. Once I've inspected, I'm then going to auscultate the abdomen. The reason we're moving and not doing our percussion and palpation before auscultation is because I want to listen to the abdomen before I've palpated, meaning that the noises I'm hearing are true noises from the abdomen and not gurgling noises that I've created by disturbing the abdomen by pressing on it. I'm going to use the diaphragm of my stethoscope, and I'm going to start listening in the patient's lower right quadrant, which is where we'll have the small intestine turning into the large intestine, and I'm going to listen up the ascending colon, across the transverse colon, and down the descending colon, and coming across slightly and listening to the sigmoid colon as well. What I'm listening for are normal gurgling bowel sounds. These have got a very wide range that encompass normal. That can be quite quiet, quite slow, and quite active as well. It's only through listening to bowel sounds regularly that you'll start to be able to pick up what abnormal truly sounds like. Particular red flags are completely absent bowel sounds, though for bowel sounds to be completely absent, you have to have listened in the same place for at least 2 minutes and not heard anything. So generally, it's only identifying the possibility of absent bowel sounds before referring them on to further care. What we may also hear are what's best described as tinkling sounds, and that's the sound of feces being impacted after a bowel obstruction, and this is also a red flag. The other thing we may hear are hyperactive bowel sounds, which are a lot of gurgling noises that are very, very active. This can be normal if the patient's suffering from diarrhea, but also it could be abnormal if we're hearing it at the distal point of the colon beyond a potential bowel obstruction, when above the bowel obstruction we're actually hearing reduced or absent bowel sounds. So that hyperactive gurgling is just coming from an empty colon rather than a fast-moving colon. So I'm going to listen now. Starting, as I say, in the right lower quadrant, I'm going to make sure I listen as low as possible, just above the patient's pelvis. And once I've heard bowel sounds, I'm going to move on. And as I'm hearing good bowel sounds here, and they're nice and frequent, they're not over or underactive, I'm quite happy to quickly move along and just sample each area of the colon. Once I've heard those bowel sounds, again, quite happily moving on. So once you've heard normal bowel sounds, it's actually quite a quick check. You just need to sample check across the abdomen to make sure they're present in all fields. Then, once I've auscultated, I'm going to now percuss. Now, there's several ways you can percuss, as long as you cover the majority of the abdomen. You can go from side to side, you can do a zigzag up and down, it doesn't really matter. What you're listening for is mixed tympany and dullness. So dullness is that dull sound on percussion, and tympany is hyperresonance, so that's air-filled. What we're expecting from the abdomen, given that we've got quite a wide range of solid and hollow organs, is a mixture. What would be abnormal is if there was widespread dullness or if there was widespread tympany. So I'm going to start by just percussing zigzag across the abdomen. I'm making sure to come right round to the patient's side, remembering that the abdomen is a 3D structure and I'm not just assessing the front window of it. If I need to reposition my hand to percuss down this side, I will do. And I'm happy that there is mixed tympany and dullness there. I'm now going to move on to abdominal palpation. I'm going to do this in 2 stages. First of all, using one hand for more gentle, soft palpation to check for any tenderness or pain. And then I'm going to move on and do it with 2 hands where I'm actually focusing on what I'm feeling during the palpation. So during my first assessment, I'm actually looking at the patient's face, not their abdomen, and I'm checking for any grimacing or any subtle signs that they could be in discomfort, even if they're not telling me that that's the case. So I'm just going to press on your abdomen, on your tummy. It shouldn't be painful. I'm sorry if it is, and I want you to tell me if it is, but it might be a little bit uncomfortable because I've got to press quite hard at certain points. But just tell me if you want me to stop or if it's unpleasant, okay? So with one hand, I'm just making sure that I assess across the full extent of the abdomen, looking at the patient's face, moving around the top of the rib cage, right round the side, moving across, right around the side again, following that rib cage, and then at the lower half of the abdomen I'm coming along, moving along the top of the pelvis, so I'm getting right down near the bladder, covering the full abdomen. Was any of that uncomfortable? No, and I couldn't see any grimacing on the patient's face. Now that I'm happy that there's no obvious tenderness there, I'm going to focus in on what I'm feeling. I'm going to press a bit deeper now, so it could be a little bit uncomfortable, but again, tell me if it's painful, because I'll stop, okay? It may be that deep palpation elicits a more hidden pain that wasn't identified. So what I'm doing here is I'm placing my non-dominant hand on the abdomen and using my dominant hand to press on top of it. So my non-dominant hand is the hand that is feeling, not the hand that is pressing. And I'm going to move across the abdomen as well. Making sure I come right round the sides, and again making sure I go right down, usually just below the line of the underpants to the top of the pelvis, so I've palpated the full bottom of the abdomen as well. What I'm looking for there is to just feel a general soft abdomen. If there's any particular swelling or ascites, it will feel firm. There may be some form of involuntary guarding where the body's protecting an underlying organ by having the abdominal muscles clench. And also, if I do feel anything particularly hard and rocky, I may be concerned that there's some underlying pathology going on there. Another thing I may feel, depending on the patient's state and what they're presenting with, is a full colon. So if you're concerned that there may be a bowel obstruction or constipation, you may also particularly focus your palpation along the line of the colon, which is where we just auscultated, and you may find that if there's a full colon in that area, it's quite clearly palpatable as you can sort of feel the feces underneath the skin. And this gives you further information regarding what you've heard on auscultation. Now that we've done our inspection, auscultation, percussion and palpation, we're going to move on to a few organ-specific checks, and we're going to start with looking at the liver. It's important to size the liver for several reasons. First of all, if the liver is lower than we'd expect in the body, that gives us a suggestion that there's actually an increased thoracic pressure pushing the diaphragm down a bit more than we'd expect, which could give us an indication of air retention in the lungs in our long-term breathing problem patients, such as COPD patients. Also, a cirrhosed liver will shrink and become more calcified and quite hard and rough, like an uneven rock against your hand if you're able to palpate it. And a swollen liver or a liver suffering from hepatitis is more likely to be larger, so you're more likely to be able to palpate it when it's not protected by the ribs. This can also occur in heart failure if there's been a backflow of blood from the heart and an increased preload. The liver can swell with portal hypertension. So to assess the liver, I'm going to start by finding the top of the liver. I'm going to find the midclavicular line on the patient's right-hand side, and I'm going to start percussing well above where I think it will be over the patient's lungs, and it should be hyper-resonant as we'd expect for lung sounds. As I move down, I will suddenly reach a period of dullness. That's the top of the liver as hollow organ goes to solid organ. That's lung, that's lung, that's lung, that's lung, that's liver. Lung, liver. Now that I've identified the top of the liver, which here is in the right place, around the 5th or 6th intercostal space, I'm going to just take note of where that is. I'm going to look to see if I've got any freckles or any marks on the skin that are a useful identifier. If not, I'm just going to keep my hand there so I know where it is. And I'm going to bring out my stethoscope, make sure it's set on diaphragm, and I'm going to place the diaphragm fully below the point that I've found so that I know the diaphragm is fully over the patient's liver. I'm going to then put my stethoscope in. And what I'm going to do now is the liver scratch test. So if you're ticklish, this may make you jump slightly, okay? But what I'm going to do is I'm going to use my fingernail, I'm going to gently scratch from the lower right quadrant of the patient's abdomen, which is well below where we expect the liver to be, and I'm going to be making a very gentle scratch up the abdomen in the midclavicular line, and I will go from hearing either nothing or a faint scratching sound to a very clear scratching sound that sounds like I'm actually scratching the diaphragm itself. When I hear that clear scratching sound, that's when I'm now above the liver. So I'm going to do that now. I'm sorry if this makes you jump, it's the first one that does. There we go. So I've got a very clear point here, and you can do that a couple of times to home in on it. Very clear, nothing at all. Very clear, nothing at all. And that's the difference of just one finger width there. So I'm happy that that's the bottom of the liver, and that's the top of the liver. So I've now sized the patient's liver, and that is around 4 inches, which isn't abnormal for a liver. So that's a nice normal size. What I'm also going to do, especially if I think the liver is swollen, is palpate the liver. Now to do this, I'm using my dominant hand, because I'm standing on this side of the patient, coming in here, and I'm going to use the radial aspect of my hand and the inside of my thumb to palpate up and into the abdomen. As I'm doing this, I'm going to instruct the patient on the way they're breathing, so that with each palpation I do, the diaphragm moves down, pushing the liver into my hand. So to do that, I'm going to say, each time I press in, can you take a deep breath in? And then I'll release and you breathe out, and we'll keep doing that together until I say that's enough. If the liver is swollen, it may be tender, so the patient might feel some discomfort which wasn't found on general palpation at this point. Okay, so deep breath in for me, and out, and in, 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 and out. There we go. So just at that last point there, I felt the very bottom edge of the liver, which is completely normal in a normal sized liver. Often you can't actually feel a normal liver on palpation because it sits just under the bottom of the rib cage, even the most distal edge. In this case, as is normal in quite a few people, we've got the edge of the ribs coming down here, and because my hand was in at an angle here compared to my earlier palpations which were straight, I've now come up to move into an angle. You can feel the edge of the liver just sliding across your fingers as the patient takes a deep breath in and as you press in. There was no pain elicited from that. If I felt like it was very rough rubbing against my finger, that could be suggestive of cirrhosis. And also if I felt that edge of the liver over my fingers lower down, that's suggesting that it's a distended, swollen liver, which we've talked about already. So now that I'm happy that the patient's liver has not given me any concerns, I'm going to move on. I'm going to do something called Murphy's test. Now this test is for the gallbladder. So we're looking in the same area, and where I'm going to do this is I'm going to find the xiphisternum here, and I'm going to find the anterior axillary line, and I'm roughly going an equal distance at the bottom of the ribs between those 2 points. So pretty much mid-clavicular line. I'm taking 2 fingers, and again, like with percussion, I'm getting them into almost a hook shape, and this can be a little bit uncomfortable even when there's not a problem, so you have to warn your patient, but it should not be painful unless we find a problem. So what I'm going to do is I'm actually going to be pressing just underneath your rib cage. It's quite deep, so it is a bit uncomfortable. I'm going to get you to take a deep breath in. The deep breath in is actually what makes it a little bit more uncomfortable, but it only lasts a second. If it hurts, just say so, and I'll take my hand away. Okay? So just breathe out for me. And in. Perfect. And out again. So as the patient's breathing in, and I'm hooking my fingers, in some cases you can even get them almost behind the ribs. He's breathing in, the diaphragm's coming down, and like with the liver, we're pushing the gallbladder, which we know is nestled within the liver, down onto your fingertips. Now that shouldn't be painful, though it is a bit uncomfortable. If the gallbladder has got an obstruction or is irritated or inflamed, it will be painful. If we elicit pain on Murphy's test, this would be termed as a positive Murphy's test. That means that on palpation of the gallbladder, we have irritated it and caused pain. This could be either because of an obstruction, it could equally be due to inflammation of the gallbladder. Either way, we now cannot say that the gallbladder isn't the problem, and in the out-of-hospital care environment, a positive Murphy's test is enough for us to transport to hospital for further investigation. I'm now going to go on to a group of tests which we're terming the appendix group tests. They all help us rule in appendicitis. What they don't do is exclude appendicitis or let us rule it out, because even if all of these tests are negative and we don't find anything on any of them, the patient may still have appendicitis, which would need to be investigated, and that's based on the history we've taken. But if any one of these tests is positive, i.e. if any of these tests elicit pain, again, that's enough for us to say we have to treat this as though it's caused by the appendix until proven otherwise in a hospital setting. So to start with, I'm going to check simply for any rebound tenderness at McBurney's point. McBurney's point is 1/3 the distance between the umbilicus, so the belly button, and the top of the right iliac crest, which we need to palpate and find here. So here's our iliac crest, here's our umbilicus, and it's about 1/3 down from that. We're going to press in, and it's actually when we release our hand that we have rebound tenderness. So you'd expect in a normal pain that when you poke it, it hurts, but in this case, that wouldn't cause much pain, or it may actually ease the pain, but on removing our hand, that's when they suddenly have pain that they weren't expecting. So to do this, if the patient has got pain in general, I'm going to be talking to them. They're going to think that pressing down will cause pain. They won't want me to touch that area. So I'm going to gently touch it, try and distract them, talk about different things, and now I'm pressing in. If that's easing the pain, they might not now notice it. We're keeping on chatting, then I'm removing it whilst looking at their face, and if I see a wince or if I see that they say that there's pain, then that is rebound positive. I'm also going to check for psoas sign. That's the psoas tendon, which we know innervates the upper leg but comes across the abdomen. So what I'm going to ask you to do is, whilst you're lying flat, I want you to raise your right leg, keep it straight, and try and touch my hand with your right knee. So just raising that leg up straight, up we go, and down again. Doing that movement tightens the psoas tendon to bring the leg up, therefore it would press on the appendix. If the appendix is inflamed, that will cause pain. So pain on raising the right leg against your hand, touching the knee, is Soez test positive, and that's query appendicitis. The last thing we're going to consider is Rovsing's sign, which is where palpation of the opposite point on the left side actually elicits pain on the right hand side. So even though I'm not touching the area of the appendix, I'm pressing on the left hand side, the patient may then experience pain at McBurney's point where the appendix is, and that's another rule in of appendicitis. The final check I'm going to do is I'm going to percuss the patient's kidneys. You can palpate the kidneys, but it's quite inconsistent and quite difficult to do, so it's not usually needed in the pre-hospital environment. Can I just get you to sit up for me and swing your legs to the other side of the bed, because I just need to get to your back, so right around. Fantastic. What I'm going to do now is I'm going to place one of my hands, usually my non-dominant hand, flat on the patient's back over where I'm expecting their kidneys to be, which in most patients will be over their lowermost floating ribs, which we know cover the back of the abdomen. What I'm going to do is I'm going to tap on my hand, so it might create some sort of movement from my hand, but I'm not actually hitting you, I'm hitting my hand. Okay? If it's painful, tell me. Now this is very important that we use our hand as a buffer, and I'm taking a fist and I'm drumming on the back of my hand like this. I'm going to do that over where I'm expecting both kidneys to be. Thank you. You can lie back now. Percussion of the kidneys lets us rule in a potential kidney problem if there is pain when we percuss them. What we're doing when we percuss is sending a vibration wave through the palm of our hand, through the posterior ribs and to the kidneys, which sit anteriorly to the posterior ribs. They hang, they are just at 3 points, so when they're hit by the vibration, they can actually swing quite easily. If they're inflamed or if there's some form of kidney stone, that will actually elicit quite a lot of pain from the patient. So after apologising and reassuring them we won't do it again, we can very clearly rule in some form of kidney problem. If we take into account the rest of our clinical picture, if the patient's pyrexic, the state of their urine output, etc., we can further differentiate between an infection and an obstruction. That concludes our abdominal assessment. If there were any other concerns we had around this patient's presentation, we may consider doing another system-specific examination, and of course we're going to complete a normal full set of observations before making any decisions based on the patient's presentation.